All right, thank you so much for joining for this month's remote monitoring working group. A couple policy updates to go through today. Um, and of course, this is our last working group meeting before our Digital Health Summit coming up next month in December in DC. And of course, if you have any questions, feel free to raise your hand or put them in the chat over the course of the meeting. So the first big policy update from the past month is the release of the final rule for the physician fee schedule for 2026. There were a number of updates in telehealth, remote monitoring, and AI in this space. And specifically when it comes to remote monitoring, of course, the big one is new RPM and RTM codes that allow for less than 16 days of data collection. Of course, prior to these codes, it required at least a minimum of 16 of 30 days. And so these are some codes that CTeL supported being implemented. Um, and so they will be in effect starting in 2026. However, it is important to note that these codes are valued less than those already existing codes. This is something that CTeL and many others submitted comments against, urging CMS to increase evaluation of these codes. And CMS's response in the final rule was to say, quote, "We appreciate the commenters for this information. We will consider additional refinements in future rulemaking." And so while CMS declined to change its proposal to value these codes less, CTeL and many others still issued our comments on that matter. There was also an RFI included in the proposal to understand what, if any, differences there are between RPM and RTM and whether or not that would affect their individual valuation, specifically whether they should continue to crosswalk their values to each other. And so CTeL, of course, provided input on this as well. And CMS response was, "We appreciate the commenters for providing further information about the differences in remote physiologic and remote therapeutic monitoring and how these services could be improved in the future. We will consider this information for future rulemaking." And so those were kind of the big remote monitoring policies included in the fee schedule. We also have a summary of all the key digital health provisions in the final rule, which is available through your member portal in our research library. Any questions on the physician fee schedule final rule? And on this slide is just a screenshot of the valuation for these new codes. You can see on the left-hand side the RTM codes that allow for 2 to 15 days in a 30-day period of monitoring, as well as some of the RPM codes on the right side as well. There wasn't really much changes in valuation between the proposed rule from this past summer and what CMS ultimately finalized in its final rule published this month. And these tables are also in the CTeL summary as well. Another important final rule that was published this month for 2026 is the outpatient prospective payment system final rule, published a little later than usual. It was published last week on the 21st. Not as much direct digital health policies as in the physician fee schedule, but some of the big ones include a 2.6% pay bump, as well as CMS continuing to expand its implementation of site-neutral payment policies, specifically concerning drug administration, as well as this proposed rule also included an RFI on software as a service pricing. This was also included in the physician fee schedule rule. CTeL provided input on that piece as well under our AI comments. And CMS acknowledged that it received comments on its RFI, but did not commit itself to any specific policies for this coming year. Any questions or comments on the outpatient prospective payment system final rule? And then finally, this is something that we've gotten a number of questions about from members, is UnitedHealthcare's RPM policy for 2026 that was recently released. The big thing here is that it would pretty strongly limit reimbursement for RPM only for patients with heart failure and or hypertensive disorders of pregnancy. Um, and anything else, any other application or use for RPM, uh, UnitedHealthcare says will be considered not medically necessary starting in 2026. And of course, this runs counter to CMS and many other payers' policies of expanding remote monitoring, reimbursement, and access and utilization. And so this was a pretty big deal to come out. And UHC is implementing this policy based on its interpretation of a Medicare rule that says that, quote, in the absence of a Medicare national coverage determination, local coverage determination, or other Medicare coverage guidance, CMS allows a Medicare Advantage organization to create its own coverage determinations using objective, evidence-based rationale relying on authoritative evidence. And so UnitedHealthcare is interpreting that to say that since Medicare doesn't have a policy specifying which specific conditions that it covers RPM for, that UnitedHealthcare can make that decision. And it has provided a list of studies that it is referencing in making this decision. And so, of course, the big implication here is if UHC is able to move forward with this, that we may see this applied to other digital health tools and technologies in the future that CMS has not made coverage determinations on, um, and that it could potentially be a limiting factor in reimbursement for digital health. Are there any questions or comments on this? I know this is something a lot of members have reached out about, and I wanted to make sure that we cover it on this call as well.
Lydia, this is Joe. Is there any effort underway or is any effort contemplated at CTeL or anywhere else that you know of to analyze the literature UHC relied upon to see whether it can be undermined as a valid basis? After all, the criteria, and I don't have the language exactly right, but it wasn't as if the feds said, you guys can do what you want. They said you can make your own decisions based upon valid evidence.
Mhm.
And I'm wondering how carefully the validity, the reliability, the strength of the evidence UHC relies upon has been or will be scrutinized. Thanks.
For sure. And this is something that we've been taking a look at as well. A lot of the studies that are referenced are from the 2010s, and so kind of really before the larger scale implementation and use of not only telehealth, but remote monitoring and other digital health technologies. Um, as well as some of the studies not even being about remote monitoring specifically, but just about like telehealth and general like virtual care integration. I put a link to the full policy, which includes the OHC's rationale in uh, the evidence and studies that it is citing for this. Some of the studies go back to like 2012 and are over 10 years old. So there's definitely been a lot of critiques leveraged just based on that and whether or not it provided a fully comprehensive review of the literature and whether or not it is using the most recent, up-to-date, and relevant literature in its decision as well. Um, because the language is pretty vague in that it says it just has to use objective evidence-based rationale relying on authoritative evidence. And so there has been some organizations who have indicated that they might challenge this policy based on its application and interpretation of this rule. Um, but that is something that we have also been looking through as well.
Thank you.
Any other questions or comments on this matter?
Lydia Joe, again, not to beat a dead horse, but if CTeL publishes on this or is looking to develop a publication, I'd be interested in knowing about that, maybe contributing if I can. Or if you learn of others who have undertaken a similar analysis, I'd be very interested in that as well, as I suspect others would. Thanks.
For sure. And this is something we're still kind of reviewing both the rationale offered by UnitedHealthcare as well as options for responding to this. And so we will continue to keep the CTeL community updated of efforts, especially if there's any sign-on or coalition efforts that you all would be able to join as well. And so those are all of the topics that we wanted to cover for today's meeting. But if there's anything that we did not cover, any questions or comments from you all, specifically on remote monitoring, feel free to raise them now. If not, then of course you are welcome to reach out to us at any time with any questions or if you'd like to set up some time to chat. Otherwise, we hope to see you next month at our Digital Health Summit in DC on December 11th and 12th. Um, you are welcome to join us in person or virtually. We will be having discussions on AI implementation, clinical workforce shortages and its implications for digital health, as well as how organizations can respond to ongoing financial and regulatory uncertainty. And so we hope to see you next month at the summit. In the meantime, of course, you are always welcome to reach out if there's any way that we can help. Have a great rest of your day, and a great rest of your week.
Happy Thanksgiving.